Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrics. David, who's our next victim at Health 2021?
Well, John, I think the next victim was going to be my stomach after that lunch you recommended, but instead we're going to shift over
You went to the wrong food truck. It wasn't my fault.
John sent me to the truck, but I went across the street to a hotel, so that was my mistake. Well, we have a couple days to make up for it. But meanwhile, we're going to make up for
There's a drug for that.
because we're going to be speaking with Carm Huntress. He's founder of RxRevu, which I dare you to spell.
Yeah, it's a
Carm,
little bit of a trick.
Carm, welcome. What is RxRevu and why did you found that?
Well, we are the leader in cost transparency, in particular, drug cost transparency at the point of care with doctors.
Why would that matter? I mean, aren't drugs affordable and prices are transparent?
John,
People, tell us more.
Is John in healthcare, David? Or
Here's the thing: we're
do
sitting
you
in
know that?
we're sitting in a glass booth with no roof, and we're talking about transparency. So that is helpful. No one's looking. Actually, people are looking at us funny, but no one's looking at us
That's
with the right.
not uncommon when you're involved.
Yeah.
Yes,
So
So drug prices are something it's a burden for every family in America. 1 out of 4 people can't afford drugs when they're on chronic meds. But how does more information help the consumer, help the doctor? Like, okay, are you just another app on top of the gajillion other apps across a broken digital infrastructure that's cluttering up the doctor's day? Like, what exactly does it do?
Yeah, so it's a great question. We really emerged as some new standards evolved around real-time drug cost. And so what's happened in the last few years is that we've moved beyond sort of generic pricing of, hey, we think you're going to pay this much when you reach the pharmacy, to, hey, patient, this is the exact price you're going to pay at the pharmacy when you reach the counter. Now, the different thing we do, unlike a lot of consumer-based applications, is we actually realized as a company that the person who makes your purchasing decision for your drugs is not you, but your doctor. And so we've really focused at getting this data. Now we can do pricing for about 150 million Americans, believe it or not. Getting this data to the point of care, to the point of decision by the doctor as they're ordering the drug.
And so as a practical matter, do doctors really change behavior? Do they really, like my 88-year-old mom or my cousin who's on chronic meds because of a chronic disease, what's going to happen when my mom or my cousin show up at the doctor and they have a new condition and walk me through exactly what's relevant there.
Yeah, so imagine you're in the exam room with your doctor and they're about to pick a new drug for you that you've never been on before. When they select that drug to be ordered and ultimately routed to your preferred pharmacy, we take that drug and your insurance information, and then we transact that with your payer or your PBM, and we bring that real-time drug cost right in front of the doctor, and we say, hey, it looks like this drug isn't covered. It's going to cost you hundreds of dollars, and or maybe it has a prior authorization on it. All that data comes back to us, and then what we say to the doctor is, hey, it turns out there's a covered drug that's just a different version of this drug. Maybe it's a generic, maybe it's a different manufacturer, and that drug is covered. It's maybe a $20 or $50 copay, and they can just switch to that drug and go on their merry way, and within their EHR, finishing the exam. And we've been able to show about a 6-to-1 ROI, and when a doctor makes a lower cost choice, the average savings we provide to a consumer is about $260 a month.
Wow.
So not some bad numbers there in terms of helping patients save money on
I
drugs.
don't know what the ROI is based on, but the $260, that's really meaningful savings for consumers.
Yeah, when we were told that number, I was actually shocked. And we verified it, and it's a really big deal. When you get misprescribed a drug that isn't covered by your insurance, it's a big deal. and you're really stuck paying a large amount of money.
And not everybody's as wealthy as David and all the other denizens of this healthcare conference. The average...
John, I knew I was here for a reason. You want to borrow $20 or $260?
Again, one out of 4 Americans who are on chronic meds can't afford their meds every month.
You know what? You hear that in every episode, John.
Well, come on. It's really important. It's relevant. Not for people like you, the BMW liberal that you are from Brookline.
I don't have a BMW, John.
How's the Tesla doing? Which one? I'm sorry. Were you going to ask a question, David?
I was going to ask a question, but I wanted to get you wound up a little bit first. So here's the thing, Carm. I mean, I don't need a point-of-care solution to know that a generic drug is cheaper than a branded drug. And also, my doctor went to medical school. He didn't go to business school. And so maybe I don't want the doctor making a decision based on price. I want a doctor making a decision that's based on what's best for me medically, and then I'll argue it out with the insurer. I'm worried about people getting headed off, and he's going to make a prescribing decision for financial reasons. Why is that good?
You want to take that one, John?
Well, no, I David, come on, really? You don't think the doctor wants to do the right thing for the patient? Your brother's a doctor. Your brother really cares about doing the best for his patients in rural New York.
I think he's getting a Tesla also, by the way.
Yeah, let's not get off topic.
But as a practical matter, David, are you suggesting that we should deny doctors information that could help patients?
John,
are you in the denial of information guy? You should join pharma.
So, there's concern about, biases people have, right? So when a physician is examining somebody, just had this discussion the other week, they'll see somebody and they may have certain conditions that say, well, that's not a disease, that Latinos get. That's an Ashkenazi disease. And so somebody doesn't get diagnosed with Crohn's or colitis because of that. And I think a similar thing could happen and say, oh, this is a cost-sensitive patient based on what they look like, and I'm only going to give them a drug that's going to be cheaper. And so I actually do worry about these second-order things. I mean, yes, of course we want to see if it's the exact same thing, I'm going to choose one versus the other. But the same way the doctors are maybe over-influenced by pharma, marketing them, telling them this or that, and all this sort of psychological tricks, I think you have to watch out for that. As a patient, I'm concerned about, what kind of assumptions someone's going to make on the financial side.
Can I? May
jump
I?
in.
Let me.
It is your show.
Let me just see.
Jump in.
Let's see if we can break
defend
this
yourself
one down.
here.
So first of all, doctors have an incredible amount of bias. I will never forget an early study I read where a bunch of data scientists took Medicare claims data, prescribing data, and were just able to look at the prescribing habits of doctors, and were able to match up to 30 years back what residency program they went to. So they are incredibly biased, and they're very habitual, and that's not necessarily best for you as a patient. The other thing I'd say that's just sort of obvious here that maybe you don't see initially is that this isn't a human decision, to be honest. It's really a computational problem. So if I have a hypertensive, high cholesterol type 2 diabetic in front of me, and I have to pick a drug for each one of those conditions, David, how many options am I sitting in front of? You want to take a guess?
Quickly,
faster.
We're on
19.
We're out of time.
19.
1.2 trillion combinatorial options, right? That's how many drugs are out there, and you just do out the math. That's the problem. And so we really see a world, and I'm just saying, that's not even cost choice. That's just drug choice, right? If we add in the complexity of your plan and your benefit, right, this is a very, very hard problem we're up against. And, today we're just sort of doing simple things that are, equivalent, right, a therapeutic equivalent that's like less expensive. I think the future here is really about intelligence and saying, where is the...
You lost him when you brought up the intelligence thing.
Well, I know that
just
happens.
Like
He just switched to a Tesla, so we have to just give him that.
Yeah. So, but David, as a practical matter, if one point, you don't like the statistic, but if people can't afford to pay for the drugs they're on, you want to deny them access to information about drugs they can afford? I mean, I think you've painted yourself into a pretty dark corner.
Well, luckily the corner behind me is glass. I'll have our producer take a photo to demonstrate
that.
I think let's jump ahead.
I think what's interesting about transparency in itself, look, I was president of Castlight. Transparency is great. It's relevant transparency at the point of care is, I think, where RxRevu has really distinguished itself. And part of changing behavior is getting the right information at the right time, which is hard, getting it into workflow, which is almost impossible, point of care, and then providing something that's really going to help patients. And I think those who think that affordability doesn't matter to people who can't afford their health care are not connected to the human pain and suffering that this healthcare system too frequently.
All right, John, Mr. Gas Guzzler. Let's actually look into the future, because that's what this conference is about. Okay, now one thing that seems interesting to me is we talk about
you're
how
stuck in the past. So let's go.
All right. So I don't, if you look ahead and you say, well, more information is actually going to help the market work better, right? We talk about having, the market doesn't work, it's broken as it relates to drug pricing. But what happens if you actually have something like RxReview that becomes ubiquitous and these signals are actually changing behavior? It seems to me that could actually affect drug pricing, negotiations, formularies, and you can actually have a more rational situation where the patient, where there's less friction between what's the right drug for the patient and what's actually covered, right? And if we look ahead, what are the implications there?
Yeah, I think what's so interesting about this market is, we're still in the very early, innings. We support about 250,000 doctors today, and there's still a long way to go. If you think about total prescribers,
how many doctors are there?
Well, if you say prescribers, we care about prescribers. Doctors, you can argue 850, 900,000 additional prescribers. Nurse practitioners, clinical pharmacists, et cetera. That puts you about 1 million, 1.1 million, 2 million. Estimates vary. So there's still a huge amount of opportunity here, just getting basic cost transparency to doctors. My belief is that we finally are getting into a world where we can measure, right? You don't know how to improve until you can measure what the cost of something is. And I think we're truly getting to that inflection point. And so what I get excited about, on top of all the great regulatory work, and there's mandates becoming behind us.
Regulatory work?
Yeah, there really is.
It's really hard to connect those two.
Here, let's connect the dot, which is...
You're taking an indefensible position, too. Tell me about
John
the
is geared up. John, what is
regulatory? Yeah, exactly.
Well, there are
what did John have for lunch today? That's what I want to know.
I don't know. He went to the Mexican food booth, apparently,
fabulous.
and he is on fire
It's
right now.
fabulous. Go.
He is on
Tell
fire.
us about your great regulatory progress.
As of this year, there is a new mandate under Part D.
What's Part D?
Part D is the pharmacy drug benefit for federally insured individuals. And basically, what it says is that all payers who support Part D members have to provide a real-time benefit tool for drug costs. So now it's a mandate because they have seen really good ROI, because we have saved patients and payers a lot of money. And so, beyond that, I think
if you don't provide that to everyone, and they have to provide it to everyone, who's providing it to those who aren't provided by RxReview? Like, what happens to those other
what the hell kind of question is that, John?
850,000 prescribers who don't have the information?
Well, that's our job right now. I think we're still in the first inning of a very long game to get this ubiquitous.
That sounds like regulatory awareness versus regulatory progress.
Well, one leads to the other, John. That's the good news. And so, look, I think that the big opportunity here is, I believe in really what RxReview can be is this transparent layer for healthcare. And, part of what's happened because of the success of pharmacy, our payer and PBM partners are now coming to us and say, hey, wait a minute, we have this new thing that can price a lab and an image and radiology and referrals. Can you get all this data into the ordering workflow? So when, the doctor makes a referral to a surgery center, or wants to order a certain lab test, we can tell them what the most effective option is, and also help the patient understand the costs. And so I think a tipping point has sort of started,
David,
now that we're really opening up the door. Yeah, David, are you trying to get in here?
No, I just want to know, John, I wanted to give you a chance to go cut the catalytic converter off your car and be a real throwback.
Clink.
Anyway, Carm, so, it sounds like we're making progress on the one hand. You mentioned these, 1.2 trillion combinations or whatever the number was. But when we have more and more drugs that are, specialty drugs, which is now like 1% of the prescriptions, but 50% plus of the cost, do you have the same sort of dynamic, where physicians prescribing? Is it more a matter of, are they going the specialty route or not? Or, does RxReview become more or less valuable when you're dealing with these expensive meds that are maybe more differentiated?
Yeah, I think it becomes more relevant because it's really a discussion about cost. These therapies are getting insanely expensive. Tens to hundreds of thousands of dollars per patient per year. There's some therapies that are incredibly exciting, and so you can have that more rational discussion with the patient if they really, can they even bear that cost? And then you have to look at alternatives opposed to sending them out to potentially bear something they really can't afford. I think the second thing I'd say, David, that I'm super excited about is the transition to value. right? We're opening up a door with the data and analytics we have to finally get to
Everybody
value.
talks about the transition
John.
of value.
Oh, my
Like,
God.
what does that even mean?
But John, look,
You're just trying to hang yourself
No,
on
I
another
really am
flag.
not,
Everybody
because-
loves value. Who's against value? It's like being against apple pie.
Hey, can we cut this guy's mic, please?
I mean, can we just say that we finally have a tool to measure? I mean, this is the thing. We live in a system where we're saying we need value. Well, how do you know something's valuable, John? You have to know what it costs.
So how do you
how
tie
do you
that-
how do you know how much David's Tesla costs?
How
I mean,
do
come on.
we pull that? How do we pull? I talked to his brother. How do we pull that through from for the single source, dramatic, targeted cancer therapy? Like, what would be these drugs are unbelievable. They're ridiculously priced, but they also are life-changing for sure. If there's not competition, is there still, for a drug category, is there still room for RxRevu?
Well, I think what's exciting is we run this transaction within the EHR to know the cost. We also can look at the clinical data. And the future of a business like this is the combination, and then making that transparent to payers and the manufacturers to say, hey, did this drug actually do what it was supposed to do?
You can tie it to the
Clinical
the
data.
electronic health record, which would include the claims post using the drug.
So,
Yeah.
certainly there are folks like ICER, Institute for Clinical and Economic Review, that is trying to have rational pricing for drugs. And they get criticized for the methodology and so on. And part of that's because it's a little bit more theoretical. Is that a good basis in terms of a framework that you can use and actually bring, real data in? Or has that become outdated once you've got your combination that you actually bring?
Well, I
real
think
time?
when you get into a real
Kind of an esoteric reference there.
it
too.
is
Like,
esoteric, but
really,
it's-
like what
We're-
were you-
I'm going to
listen,
go with it.
We're in Boston, not Vegas. We can
Yeah.
handle intellectual question here.
Yeah, that was a pretty heavy. I mean, that was like an MIT,
Yeah,
or
good,
should I say
very
Harvard?
impressive. Check.
Yeah,
Check,
Harvard
yeah.
level question.
Yeah, how many
That was-
degrees from Harvard does John have? I forgot.
Well,
Answer the question as asked.
as asked. So I think we are on a better trajectory, right? Because it really comes down to the individual patient, the plan, the drug, the cost, the clinical data. Creating that combinatorial thing really gives you the infrastructure necessary to move into value. And I think that's really where the future of this whole industry is going. And so that's where I get really excited about where we can go, because we are up against, if you think what's coming, right, and you think about these new therapies, whether it's oncology, John, you brought up, or these curative things, we have some really tough economic decisions to make. And if we're not measuring and understanding the effectiveness against the other options, we don't really know how to rationalize these things.
I mean, I think, saying we're on a trajectory, a good trajectory is saying we're not in the right place yet. It's what I tell my kids when they aren't really doing what they're supposed to do. But even someone as data insensitive as David has got to admit that we should actually measure the results of the drugs that we're prescribing. That doesn't happen today.
We are just getting to that level of measurement. I mean, I think the industry, if you look historically, we've really relied on static data sources like formulary and benefit to sort of know what the patient cost is going to be, and that's completely inaccurate to what they actually pay at the pharmacy when they get to the counter, because it doesn't include deductibles or accumulators or co-insurance. The list just goes on of complexity that a patient's up against when they need to pay. So look, John, we've got to really rationalize this towards, what's the patient going to pay, and how are we measuring, right, the clinical value that's providing a patient. That's ultimately what this comes down to.
So maybe last question, Carm, you mentioned all of the different elements and all the complexity on the health insurance side. What about coupons and things that might go outside of insurance? I mean, how does that play into someone's
you're
decision?
like pharma-friendly question.
You know what? I tried to ask a. I was going to give John
Coupons.
the chance to ask the last question.
Manipulation
but I said,
is what they are.
Or ask a question disguised as a statement disguised as a question. But I thought I would ask a quick.
So look, so again, let's pay attention to the end zone, which is what I want to do when the doctor's making the decision. If I really had ultimate knowledge and information, as I would go out and I would say, what is the lowest cost option drug that is most convenient to the patient? That's the question I'm trying to answer. And so these things like coupons and manufacturer discounts and some of the other, manufacturer programs.
Juiced manipulation of the market.
Just
David.
Just like the food truck David went to, the juice truck. Did you go to the juice truck?
No, it came over here. John was complaining they didn't give him a high enough dosage.
But I think that there's a really interesting information dislocation that I don't think we're aware of. I certainly was only aware of the pricing challenge. And even though David doesn't understand what middle class and poor people have to pay, the reality is that more and more of the burden of actual paying, not forget the consumer-driven plans where the patient or the member, the insured takes total risk, but the increase in deductibles, coinsurance, and actually benefit coverage, more of that dollars are being paid by families, working families that can't afford it. And I think that's powerful, but the notion that you can actually innovate around outcomes, that's really exciting. And so thanks for joining us.
Yeah, guys, this has been great. I hope you get your car issues sorted out, but this has been a pleasure. Thank you.
Well, we'll go check it out in the garage. In any case, that's it for yet another edition of CareTalk here at Health 2021. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for listening, and please subscribe on your favorite service. And thanks, Carm, for joining us.
Thank you.